Although global, it is considered a rare group of malignancies. They account for only about 3 to 7% of malignancies that affect the uterine body. Of course, we know the commonest are the endometrial adenocarcinomas, and they account for about 1% of gynecological malignancies. But that notwithstanding, we are seeing more and more of these cases. Of course, we do not have Kenyan figures, but at least each week you will see 2 or 3 in our gynecology clinics in our hospitals, either here or KU. And out of these uterine sarcomas, majority, about 60%, constitute leiomyosarcomas, which, as we know, there is some association with fibroids because both arise from the smooth muscle cell and connective tissue of the uterus. Then about 40% is what we call endometrial stromosarcoma. These are malignancies that affect the inner lining of the connective tissue lining of the uterine cavity, and other variants account for about 80%. In terms of the incidence and all that, it's been noticed that the frequencies or the prevalence is higher amongst Black women as compared to the Caucasians. And the median age of all this in general is about 35 to 65 years. And that's when there is a peak of these particular conditions. The other risk factors, the main one, there is no clear-cut direct cause of this, so it's what you call idiopathic, but a good number is because of genetic mutations, meaning if there is this condition in the family, then the daughters stand some element of a risk. Those who have been exposed to radiation before, like the women who have had radiotherapy for cancer of the cervix, cancer of the breast, or cancer of the vulva, it significantly increases their risk to develop these particular conditions of uterine sarcomas. Those with obesity, of course, the risk is increased. Family history ties in with the genetic aspect as a risk factor. So in terms of classification, and I will try and make it easy because I know we have a wide audience. One wouldn't do it the way you'll do to purely a gynaecology class. The first group is the endometrioid sarcomas. Like I said, these are the ones that will affect the inner lining of the uterus, basically the connective tissue, what is thought to be a tissue of mesenchymal origin. And in endometrial stromosarcomas, you have various variants categorized under that, depending on the level of differentiation of the tissue. So if it's poorly differentiated, it will be low grade. If it's well differentiated, moderate, it will be poorly will be high grade, and like that. So you have endometrial stromosarcoma, low grade potential. You have endometrial nodule, which is thought to be a benign condition, and you have the endometrial stromosarcoma high grade, which is now the more aggressive variant of this. Of course, the other group is those that arise from smooth muscles. We are talking of the uterine sarcomas in general. And the commonest, like we said, is the leiomyosarcoma, and that can be of myxoid or epithelioid variants. And these ones are thought to arise from the smooth muscle cells and connective tissue of the uterus. And as we know, smooth muscle cells are the ones that give rise to the benign condition, which is common in most of our women, the uterine fibroids. But they do not this doesn't necessarily arise from uterine myomas. It's more of the smooth muscle cells of the uterus. Then you have what is called a tumor of smooth muscle cells of unknown potential, where on analysis, the differentiation does not clearly give what one is dealing with. And then there is a variant which some classifications might not put it straight here, called carcinosarcoma, which is more of an epithelial tumor, but the other term we use for it is mixed Mullerian malignant tumor, MMMT, which tends to be very aggressive and which is also fairly aggressive, and we'll have a small discussion about it at the end. So let's now go to each of the variants. Leiomyosarcoma, like I said, this is a sarcomatous tumor that arises from the smooth muscle cells of the uterus or cells of mesenchymal origin, and these are mostly the connective tissue within the uterine tissue. Radiation is a main risk factor, but other than that, as one ages, then the risk increases with age significantly. Are you able to run? Yeah, if you're able to run the slides, that's better. Just proceed until where there is leiomyosarcoma. So next. Yes, we are there. Yeah, so like I said, arising from the smooth muscle cells, radiation is a significant risk factor. Also, as one ages, like with all cancers, the risk of developing this becomes more frequent. So if you see a lady in their 60s and you find they have this uterine fibroid-like growths that are increasing in size and causing pain and causing bleeding, then you know most likely you are not dealing with just benign uterine fibroids. That most likely is going to be, on histology, a leiomyosarcoma. So this should be addressed with the urgency it deserves. And how pathologists make a diagnosis of this on histology is this tissue has very high mitotic activity, more than 10 cells per mitotic index per high power field cellular atypia, and there's an element of necrosis even on gross examination. I might add that at this point, most of this is, the diagnosis is made postoperatively after one goes to do surgery, say for uterine fibroids, then you subject the specimen for histology, and that's when the diagnosis is made. And the other important thing to remember, there are no reliable tumor markers which one can use as a screening tool to pick out this particular condition. Of importance also is to note that leiomyosarcomas are very aggressive tumors. So if they are not addressed early, by the time you pick them, they will have metastasized. And the most common metastatic route is hematogenous through the blood system, and you'll find nodules in the lungs, the liver, depending on the extent of metastasis at the time of diagnosis. So early diagnosis
Dr. Mokomba, we lost you.
Yeah, I'm back. I was saying for leiomyosarcomas, they are very aggressive. They metastasize through the blood system. You got me earlier than that, sorry.
No, we are okay. We are fine.
Okay. So that belies the importance of early diagnosis, because if there is a delay, then you'll get this condition when it has already spread to the lungs, the liver, and other organs. So early diagnosis is very, very important. I think the previous slide, please. Give me the previous slide, please. Oh, it's not running the slides the way I would wish. But nevertheless, we continue. So still on leiomyosarcomas, most of the workup is through imaging. And in terms of imaging, the imaging is the internet is not very good, but we continue. So I was saying in terms of diagnosis, mostly after taking the history and physical examination, the commonest complaint tends to be either abnormal vaginal bleeding, abdominal distension, abdominal pain, and then with a proper physical examination, you might be likely to get a pelvic mass, which might or might not be tender, might have firm and soft areas associated with pain because of necrosis. Then the index of suspicion is increased. But in addition, you can do imaging, magnetic resonance imaging, MRI, should be able to pick it fairly well, and it will show solid areas with areas of necrosis, and it might even be able to show areas of infiltration into the surrounding muscle. That will increase the index of suspicion. Where there is no MRI, one can do a CT scan. The other important thing, because of the early metastasis, it is recommended to do a CT scan of the chest to rule out chest metastasis, because that will be the first point of spread of leiomyosarcomas. And also, once we operate on these ladies with or suspected leiomyosarcomas, or for any other condition for that matter, it is extremely important to submit the specimens for histology. It is as important, if not more important, than the surgery itself, because if we do not, then the disease is likely to recur sooner than later, and all the temporary gains that will have been obtained through surgery will be lost if we do not do histology. I know it's a challenge, especially in the far-off counties, but at least if you convince the patient there are courier services that can take the specimen to the nearest county where there is a pathologist, because it's extremely important. Any tissue removed from the human body must be subjected to histology, so that if there is requirement of additional treatment, then that can be effected. How do we manage patients with suspected or confirmed leiomyosarcoma? Of course, the primary treatment should be surgical excision. And what we do is a staging laparotomy, where you open and then take a peritoneal fluid sample. You are trying to look where there are malignant cells for the purposes of staging. And then after that, then we do a total abdominal hysterectomy and bilateral salpingoophorectomy. The salpingoophorectomy is done because some of these tumors are test positive for estrogen and progesterone. That's ER/PR receptors, meaning they respond to hormonal stimulation. some of them. So it's important to do the salpingo-oophorectomy part. The risk of recurrence, even after surgery, is high, almost 50%. We've seen patients who have had surgery and barely 3 months later, they have a mass that is bigger than what you removed. And that's if the histology comes back as leiomyosarcoma. So to prevent that, one can institute additional treatment measures, and mainly radiotherapy and chemotherapy. The unfortunate bit is it's been shown that not a big advantage is gained by doing either of these two, but it's been shown that those who have pelvic radiation after surgery tend to reduce the risk of recurrence by half. And those who get chemotherapy, they have across the board almost a 20% positive response rate. So they have a place in terms of treatment. People have used the targeted immunotherapy elsewhere, and the one I came across common is pazopanib and bevacizumab, and they are being combined with the other chemotherapy agents like doxorubicin, gemcitabine, ifosfamide, with varied response rates. In our own experience, the patients we've had patients with this condition after the primary surgeries, and actually they have done fairly well with additional chemotherapy and radiotherapy. But by 2 years, you find a good number of them have recurrence. But with constant monitoring, then you're able even to pick the recurrence and be able to see whether there is any treatment you can give. I remember we had one who, after the initial surgery, we did a second surgery, then gave chemotherapy and radiotherapy. Now, after all that, she developed a paraaortic node disease, which were quite big. And she went in, the cardiovascular surgeons were able to actually resect that part of the aorta and put a graft and remove the tumor. And I saw her recently, 2 years after that, doing very well. Luckily, no evidence of metastasis so far. Next slide. Yeah, okay, let's move. We've talked about that. That's just a recap of the treatment options and the studies that have been done. So that's as far as leiomyosarcoma is concerned. So like I said, it's fairly common amongst Blacks, and knowing how common uterine fibroids are amongst Blacks, then you know those smooth muscle cells of the uterus are potential to develop this. So high index of suspicion where you have a rapidly enlarging uterus, fibroids that were initially slow growing, then you have a rapid increase in size. We should be able to suspect or have an index of suspicion for leiomyosarcoma and have it managed as appropriate. The next one is now endometrial stromosarcoma group. Like I said, the endometrium is the inner lining of the uterus. It has the epithelial lining, the endometrium, which gives by and large the commonest malignancies that affect the uterus. That's the endometrial adenocarcinomas, endometrial CA in short, which are various variants, and they tend to be more common across the population. But we also do see this variant, which is a sarcoma. So like we said, the origin is from the endometrial stroma. They are not as common, like in the primary facilities, one might not see this. We might be seeing more in the tertiary institutions because of referral. Occurs more commonly among elderly women in the 50 to 60 years age group. And commonly they present with abnormal bleeding and diagnosis before surgery is by endometrial sampling, either through the traditional DNC
Dr. Mokomba, we lost you again. Dr. Mokomba, can you hear us? Let's give him a few minutes, maybe a minute or so to rejoin.
sarcomas. And there are three main types. There's endometrial stroma nodule, which is normally a nodular mass that grows within the endometrial cavity. It has no myometrial invasion, and it does not invade the lymphovascular space, and it's considered to be benign. Then secondly, you have the low-grade endometrial stromosarcoma, which affects from the perimenopausal age group. This one, the difference between that and endometrial stroma nodule is that it's invasive. Normally, benign tumors are not invasive. They not invade the surrounding structures. There are slow-growing tumors, the low-grade endometrial stromosarcomas, and they'll affect the myometrium and the lymphovascular space. And on immunohistochemistry, we'll test CD10 positive, ER positive, PR positive, basically the hormone receptors markers. And they are thought to arise from genetic abnormalities, which I'll not go into details with. When they are discovered early for low-grade endometrial stromosarcomas, the management is surgical excision, early surgical excision. It is found fairly early because of the aspect of abnormal bleeding, total abdominal hysterectomy, and bilateral salpingorectomy. The BSO is because of the aspect of hormone receptor status. So you want to deprive the tumor of the influence of estrogen and progesterone hormones. There is no need for lymph node dissection in this case of low-grade endometrial sarcoma. Okay, it has an excellent survival of in 5 years when managed appropriately. More than 80% of those who get disease can survive. Next slide. Yeah, so next is a high-grade endometrial stromosarcoma. Yeah, like it reads, this is an aggressive variant of endometrial stromosarcoma. It has poorer differentiation. Yeah, poor differentiation. When cells are poorly differentiated, they tend to be more aggressive in its growth, and it invades into the surrounding myometrium as well as the lymphovascular space. The difference between that and the low grade, it has more mitotic index per high power field. Because of the aggressive nature, the outcomes tend to be poor because you'll have a patient with a rapidly growing mass. By the time you discover it has actually breached through the myometrium and growing into the abdominal cavity. I remember a patient I had recently with that, and she had a big tumor over the uterine fundus invading into gut and the omentum. And you can imagine the kind of prognosis we'll have. They say it gives tongue-like projections into the peritoneal cavity through the myometrial wall.
Alfred, we lost you again.
Sorry, internet issues again. So I was saying it's very aggressive, the high-grade endometrial stromas. It does not have the estrogen and progesterone receptors. Therefore, even at some point, you cannot use a hormonal treatment. So in terms of management, also diagnosis is through assessment of endometrial biopsies, and you get the histology of high-grade endometrial sarcoma. Management is surgical resection. That is the best management. Total abdominal hysterectomy and bilateral salpingo-oophorectomy. And because of its aggressive nature, it might be good for some element of omentectomy. After that, because again it's aggressive and tends to recur very quickly, then it needs adjuvant therapy, that is treatment after surgery, and there is use of chemotherapy. There are many chemotherapeutic agents that are used. Also, there is use of radiotherapy, which helps to reduce the risk and rate of recurrence of pelvic tumors after surgery. Okay. So yeah, that broadly covers the high-grade endometrial stromal sarcoma. There are many tests to try and see what can be used in treatment on top, especially as far as chemotherapeutic agents are concerned. Then the other group we have is undifferentiated sarcomas, like high-grade epithelioma and spindle cell.
Dr. Bokomba is having a lot of internet challenges. Let's bear the situation.
Yeah, the other variants is high-grade epithelioma, spindle cell tumors, and like the other sarcomas, treatment is with surgical excision when discovered early. We can go forward with the slides so that we catch up. Let's next slide. Next one, please. Those ones I've talked about that. The next slide. Yes, the next group that I will talk about is one that we also do see, and it falls between epithelial and mesenchymal tissue of origin. So it's a mixed kind of sarcoma, affects mostly the endometrial lining, but of course, being a malignant, it will invade if not treated early. It tends, if the one of carcinosarcoma, it invades into the myometrium, and if not treated, of course, it will metastasize. So it has, the carcinosarcoma has mixed epithelial and sarcomatous tumors, and the epithelial ones tend to be all the variants that you can find in endometrial adenocarcinomas. You can have endometrioid elements, you can have mucinous, you can have serous, you can have clear cell elements, epithelial elements within this tumor, and then derivatives from smooth muscle and connective tissue of the endometrial lining. The commonest symptomatology is abnormal vaginal bleeding, be it postmenopausal, perimenopausal bleeding, and in 50% of cases, by the time the diagnosis is made, there is already metastasis to distant organs. 5 years survival, only 20% of the patients who are diagnosed with this condition will be alive in 5 years. So that tells you the aggressive nature of this condition. Management is surgery again, total abdominal hysterectomy, bilateral salpingo-oophorectomy, and I think sometimes we had the pelvic lymph node dissection. Of course, after doing a full metastatic workup to rule out tests, metastasis and metastasis to other body organs. Again, adjuvant treatment is necessary with either chemotherapy and radiotherapy, especially pelvic radiotherapy, to try and reduce the risk of pelvic recurrence. And in cases where there is no distant metastasis, it helps in improving the local control of the disease. Of course, if there is already distant metastasis, then this might not be very useful in terms of improving the patient's survival chances. Okay, we have talked about that. So the next slide. So I think I've talked about the chemotherapy. I will end it there. So that is a summary of the various conditions that we encounter as far as uterine sarcomas are done. My sincere apologies for the internet interruptions and the technical issue at the beginning, because I ducked straight from a surgical operation, which was unavoidable. Dr. Odongo.
Thank you very much, Dr. Mokomba. I'll just take a few questions.
Maybe Dr. Odongo, before you proceed, maybe I could say a word. Thank you, Dr. Mokomba, for the presentation. Apologies for the technical hitches we've had with the presentation today, but we've managed to share it through the chat box. You can be able to get a copy of the presentation in PDF and also follow through what Dr. Ari has taught today. Thank you. You can proceed.
Thank you. Dr. Mokomba, the first question, is there a screening test for brain sarcomas?
Yeah, unfortunately, there are no tumor markers which one can do to follow up on this, and no definitive screening tests that have been determined. So most times it is through the symptomatology when people already have this condition and the high index of suspicion. So unfortunately, no reliable screening tests.
Thank you. The other question is, does endometriosis predispose to sarcomas?
Not quite. What it might predispose one to is to get endometriosis can be a risk factor for epithelial ovarian tumors, especially of the endometrioid type. Yes, not sarcomas per se, but it is a risk factor for C ovary. And before I forget to digress, Dr. Odongo, I want to emphasize to our audience the value of something different, that as far as cancer of the cervix is concerned, the HPV vaccines in the market are very, very safe. They have been proven to be effective, and have no significant harm. So people do not have to fear giving it to our women. And all women are eligible from age 10 all the way to about 45, unless one already has CS cervix. So it's something that Dr. Odongo, we should re-emphasize at every forum. There has been a lot of misinformation on the HPV vaccine, which is not correct. The correct stand is that these vaccines are safe and they do help in preventing this debilitating disease called CS cervix. So that's a digression, but nevertheless important.
Yeah, we have a few more minutes, but I didn't hear you mention about adenosarcomas. Maybe it was in your slide at some point.
Sorry?
I didn't hear you mention adenosarcomas. Okay. Would it have been in your slides at some point?
Yeah, unless I check, okay. Must have let it out some, but it's okay. It's in the slides.
Okay, thank you. So I'm not seeing any other. I think you've answered this question. Someone asked, when should HPV vaccine be administered and to who? You've already said up from 10 years all the way to 45 years. I think that's
so even women who are sexually active can get the vaccine. That's a very common question. The thing to emphasize is the high index of suspicion. People with abnormal bleeding should be investigated for any possible cause. Just like if any man had a cut somewhere, you'll go to the hospital to have that place stitched. So if women are bleeding, they should come out and say so that we investigate the cause. And for us, especially the health workers, if women have masses that are rapidly increasing in size, the index of suspicion even for this sarcoma should be high, and make sure histology is done. Histology is so important. I think because of the early unavailability, most people would discard those specimens after surgery. You must emphasize to the patient that histology is as important, or if not more important, than the surgery, because it determines the complete treatment and therefore the survival of this patient. And so long as the tissues are well preserved, they can stay for long, even if they are not transported immediately to a site where they can be examined.
Okay, maybe the last question is about sarcomas in children. We've seen children who come with vaginal bleeding. Maybe it's also in your slides, but maybe just make a comment on that.
Yeah. Yes, children also do get sarcomas that affect the reproductive system, the commonest being rhabdomyosarcoma, where you have a child who comes bleeding, and on examination, you find there's either a tumor protruding through the vaginal canal or through the cervix and the endocervix, and they tend to be very aggressive tumors. So even in small children, this can occur all the way up to teenagers. We've had several. And again, if found early, the best treatment would be surgery. The challenge being, once you do these surgeries, fertility sparing, because the surgeries have to be a bit radical to achieve good outcomes. But in that scenario, then one weighs between having the child alive without fertility per se, or having the child remain with the tumor and die. In selected cases, the ovaries can be preserved for future over-harvesting. So these conditions also do occur even in children and young girls, although they are more common now. The other variants are more common in the adults.
Thank you. I'm not seeing any other question on the chat box, and I'll take it back to our KNH research office to bring this to a close. Asanteni sana.